workforce is the major single item of expenditure. 60% of health expenditures go on the workforce. So clearly, if we're going to improve service delivery, the workforce is key to that. So as new technologies develop, as pressures emerge on health budgets, we're looking at ways of reconstructing the health workforce. The question is, do we work with established professions, or is there a role for new professions? That's what you're suggesting. I would like to say, in answer to your question, that the research evidence is substantial, but in fact it is very sparse. It tells us a little bit about how patients value the contributions of some of the new professionals, such as advanced practice nurses, for example. But in terms of the real questions we want to address, which are the clinical and the cost effectiveness of both of these, of the new professions, we really don't know. And that's why I am currently directing a large EU-funded project which looks at exactly these questions. We've got 9 partner countries within the EU, although one of them is in fact a new applicant country, that's Turkey. And what we're looking at is to assess the clinical and the cost effectiveness of new professional roles within our partner countries, with a view ultimately to determining what role they can play in service redesign, and then feeding that through into the sort of tools that redesigners use, which are workforce planning models. So that's where we're heading. Technology is changing, and so it's simplifying some of the procedures that we or our medical colleagues can undertake. It may be that you don't need the full skill set you get from a fully trained medical professional to deliver those procedures. So that's one reason. There are aspects of service delivery, scribing, taking bloods, things like these sorts of aspects of service that may be more appropriately delivered by different professionals than have in the past. And so I think it's entirely appropriate that new professions are developing, but what we don't understand is the full contribution to both clinical outcomes and their cost effectiveness, as I've suggested already. But it's understandable why health professionals, having invested substantial time and resources in training to a very high standard, should be reluctant to see the returns from that training diminished. But that's the nature of the labour market. We all are exposed to that hazard, and there's no reason why health professionals should be any different from other occupations. What I think is going to require to motivate change is not just the evidence that the new profession can make a contribution, but a change in incentives for professionals to move and to change practice. I think general practice in the UK is an interesting example where, as a result of essentially a set of financial incentives which have induced general practitioners to deliver the service in a different way. So we find more advanced practice nurses now delivering a service in general practice. We're finding them moving from the partnership model to often employing salaried GPs. They're doing both of these things because there are financial returns to the partners in the general practice from adopting these new professions, from employing salary rather than further partners. So financial incentives work.